This presentation on endogenous interference, hemolysis, icterus, lipemia has been created for the University of Alberta Medical Laboratory Science Program and is presented by Dr. Karen Matika. Copyrighted material contained herein is reproduced under subsection 29 through 29.4 of the Canadian Copyright Act. This presentation is available for your individual use. Further distribution will infringe copyright. I highly recommend you read Chapter 3, Pre-Analytical Variation, in the 8th edition of Teats Fundamentals of Clinical Chemistry and Molecular Diagnostics. In this presentation, we will cover the following learning objectives. By the end of the presentation, the learner should be able to describe pre-analytical errors, differentiate between endogenous and exogenous interference, describe hemolysis, icterus, and lipemia, explain how hemolysis, icterus, and lipemia can cause interference in chemistry assays, and provide examples. The learner should also be able to discuss automated hemolysis, icterus, lipemia indices. Lab errors can be classified as to when they occur in the lab. There are 3 categories: pre-analytical errors, analytical errors, and post-analytical errors. In some textbooks, the word analytical has been substituted for examination. Thus, pre-examination, examination, and post-examination errors. In pre-analytical errors, these errors occur during test requesting, patient preparation, sampling transport, delivery of the sample to the well, as well as sample handling before analysis, for example, centrifuging and aliquoting specimens. Interference occurs when a substance or process falsely alters an assay result. Interference can lead to falsely increased or falsely decreased concentrations of a measured analyte. Interferences are classified as endogenous or exogenous. Endogenous interferences are substances naturally present in the patient's own specimen, for example, hemolysis, icterus, lipemia, paraproteins, and glucose. Exogenous interference are substances introduced into the patient's sample, for example, anticoagulants, collection tube gels, intravenous infusions, drugs, both recreational and therapeutic, vitamins, and herbal supplements. Hemolysis may be defined as the release of hemoglobin and other intracellular components of erythrocytes into the plasma or serum. Hemolysis may occur in vivo or in vitro. In vivo hemolysis that occurs in the body can be caused by hemolytic anemias, hereditary disorders of erythrocytes such as thalassemia, and transfusion reactions. Most instances of hemolyzed blood specimens are the result of in vitro hemolysis. In vitro hemolysis is caused by poor collection technique, mishandling of the specimen during transport, and specimen handling errors. Hemolysis has been recognized as the most frequent pre-analytical artifact encountered in laboratory specimens. Hemolysis can cause interference in assays by a variety of mechanisms. The first that we will discuss is the additive effect. As you know, red blood cells contain hemoglobin, which in turn carries iron. Erythrocytes also contain potassium, magnesium, and inorganic phosphates, as well as many enzymes at higher concentrations than that found in plasma. Subsequently, when red blood cells lyse, the concentration of these analytes is falsely increased in the plasma. For example, potassium, magnesium, phosphate, iron, ALT, ALP, AST, and LD. Hemolysis can also cause interference through what is known as the dilutional effect. As you know, when red blood cells lyse, they release their cellular contents. This includes intracellular fluid. When a large number of red blood cells lyse, this added fluid can have a dilutional effect. This effect is most commonly observed in analytes that are found at a high concentration in the blood, such as albumin, bilirubin, sodium, and glucose. Spectral interference with hemolysis is well known in the lab. When red blood cells lyse, hemoglobin is released. Normally, in vivo, free hemoglobin is bound by the serum protein haptoglobin. When the haptoglobin is saturated, free hemoglobin can be detected in the serum. Free hemoglobin has two forms, oxygenated and deoxygenated. These two substances account for the red tinge of the hemolyzed blood. Hemoglobin strongly absorbs light between 320 and 450 nanometers, and also between 540 and 580 nanometers. Subsequently, hemoglobin may cause spectral interference in assays that use absorbance measurements at these wavelengths. The extent of the interference is dependent on the concentration of free hemoglobin in the sample and the presence of other endogenous or exogenous interferents. During cell lysis, hemoglobin is released. Hemoglobin can act as a chemical interferent. The heme subunit of hemoglobin has pseudoperoxidase activity. This pseudoperoxidase activity interferes with reactions that use hydrogen peroxide as a reagent to catalyze the oxidation of colorless chromogens to the colored form. Heme can also be oxidized by hydrogen peroxide. This may result in a decreased production of the colored chromogen. It is important to note that although hemoglobin may cause negative interference in hydrogen peroxide assays, if there is spectral overlap between hemoglobin and the measured oxidized chromogen, the net interference may be positive. The next endogenous interferent we will discuss is icterus. Icterus refers to the yellow color of a sample, and it is the result of an abnormally high concentration of bilirubin in the sample. Hyperbilirubinemia is the term for increased bilirubin in the blood. It can be caused by liver diseases, such as viral hepatitis, and by conditions that cause in vitro hemolysis, such as malaria and sickle cell disease. As you can imagine, the presence of a yellow chromogen like bilirubin can cause spectral interference. Bilirubin absorbs light between 400 and 540 nanometers, with a maximum absorbance of 460 nanometers. Bilirubin is known to cause spectral interference in several routine chemistry assays, such as phosphate and creatinine. Bilirubin may also cause chemical interference. Bilirubin is an antioxidant and is known to interfere in assays that use hydrogen peroxide to catalyze the oxidation of a colorless chromogen to a colored form. Bilirubin destroys part of the reactive intermediate formed in the peroxidase reaction, and thus decreases the amount of colored product produced. As with hemolysis, it's important to note that although bilirubin may cause negative interference in hydrogen peroxide reactions, if there is spectral overlap between bilirubin and the measured oxidized chromogen, the net interference may be positive. The next interferent we will discuss is lipemia. When we talk about lipemia, we also need to talk about turbimetry. Turbimetry is the measure of scattered light. When parallel beams of light encounter a particle, the light is absorbed, transmitted, scattered, and reflected by the particle. Lipemia is turbidity resulting from light scatter due to a high concentration of lipoproteins. Most commonly, lipemia is caused by the recent ingestion of a fatty meal. It has been reported to be the most common interferent in outpatient samples. Requiring patients to fast prior to blood collection can reduce the number of lipemic samples coming to the lab. Lipemia is also associated with alcoholism, diabetes mellitus, and certain medications, as well as some hereditary diseases such as familial lipoprotein lipase deficiency. The diagram on this slide illustrates the relative sizes of lipoproteins. Chylomicrons are the largest. They are 70 to 1,000 nanometers in diameter. Very low density lipoproteins, known as VLDLs, range in size between 27 to 200 nanometers in diameter. Low density lipoproteins, LDLs, range in size from 20 to 26 nanometers. The smallest lipoprotein is the high-density lipoprotein, HDL. They are 6 to 12.5 nanometers in diameter. Chylomicrons and VLDL particles contribute to the turbidity of a sample. Light scatter is a function of particle size and the wavelength of the incident light. On this slide, there are 3 images illustrating the different types of light scatter. Double arrows represent the incoming beam of light, and single arrows show the direction and intensity of the light that is being scattered. In Rayleigh scatter, the particle size is significantly smaller than the wavelength of light, and the light scattered symmetrically forward and backwards, but very minimally at 90 degrees. In Rayleigh-Debye scatter, the particle is approximately equal to the size of the wavelength of light. This results in asymmetric light scatter. Most of the light is scattered forwards, but some of the light is still scattered to the side and backwards. In Mie scattering, the particle size is larger than the wavelength of the incoming light. This primarily results in forward light scatter. If you recall, chylomicrons are very large, 1,000 nanometers, and would be greater than the incoming light used in most assays. Spectral interference caused by lipemia is most significant when shorter wavelengths of light are used. That is, the wavelength of light is smaller than the size of the particle. Assays that measure the conversion of NADH to NAD, or the reverse, are measured at 340 nanometers and are especially prone to interference from lipemia. For example, lactate and phosphate are measured at 340 nanometers. Lipemia may also cause interference through the partitioning effect. The partitioning effect describes the preference for polar analytes to partition in the aqueous phase of blood. For example, sodium preferentially partitions in the aqueous phase. Conversely, fat-soluble vitamins like vitamin A and D, and steroid hormones like estrogen, as well as hydrophobic drugs, prefer to partition in the nonpolar phase. Normally, human serum is approximately 8% lipids, and these lipids do not rise to the top of the tube. However, lipids such as chylomicrons tend to form a layer at the top of the sample. The chylomicrons will carry fat-soluble analytes to the top of the tube. The problem occurs when sampling the specimen. In automated analyzers, the probe will drop down below the surface. If the probe depth is within the fatty layer, the concentration of polar analytes will be lower and inaccurate. However, it is also possible for the probe to drop below the fatty layer and withdraw only from the aqueous layer. This would cause a lower concentration of the nonpolar analytes. Similar to the partition effect, lipemia can also cause an error through what's known as volume displacement. Normally, plasma, as I mentioned, or serum is approximately 92% water and 8% lipids. In a lipemic sample, the proportion of the lipid phase increases and can be up to 25%. Analytes that are not distributed in the lipid phase are distributed in the aqueous phase of the sample, which now accounts for only 75% of the sample. You can see that in this diagram. We have the normal plasma with 8% lipids, and we have 92% water, and we have approximately 20 molecules of a substance. In the lipemic sample, we have 25% lipids and 75% aqueous phase, and we have the same amount of analyte, 20 molecules, but it's in a smaller volume. Volume displacement most notably affects the electrolytes and is often referred to in textbooks as the electrolyte exclusion effect. The course textbook, Teats Fundamentals of Clinical Chemistry and Molecular Diagnostics, describes the electrolyte exclusion effect as the exclusion of electrolytes from the fraction of total plasma volume that is occupied by solids, which leads to the underestimation of electrolyte concentrations. Indirect ion-selected electrodes measure the concentration of electrolytes in diluted samples. This results in a falsely decreased concentration of electrolytes. Direct ion-selective electrodes measure the concentration of electrolytes without a dilution and are not affected by lipemia. In the indirect ISC methodology, the patient sample is diluted prior to measurement. Normally, this dilution has no effect on the accuracy of the measurement. However, if the sample has an abnormally large fraction of lipids or proteins, the dilution underestimates the electrolyte concentration. In the figure on this slide, we have a normal sample and a lipemic sample. The liquid portion of the plasma is represented by yellow, and the lipid portion is represented by orange. The black dots represent sodium. On the left-hand side of the slide, we have an undiluted normal plasma sample and a diluted normal plasma sample. In the normal plasma on the far left, we have 20 sodiums in 92 microliters. So the concentration of sodium is 20 divided by 92. This equals 0.217. When the normal plasma is diluted 1 and 2, the figure on the right, the result is 10 sodium ions in 96 microliters. The concentration is 0.104. If we multiply that diluted concentration by 2, the dilution factor, we get a concentration of 0.208. This is only slightly different from the undiluted value. On the right-hand side of the slide, we have an undiluted and diluted lipemic plasma sample. In the lipemic plasma, we can see we have 75% liquid and 25% solids. You can again see that in the liquid portion, there are 20 sodium ions, but they have been confined to a smaller physical space than in the normal sample. The concentration of sodium in this sample is 20 divided by 75 microliters, which equals 0.266. When the lipemic sample is diluted 1 and 2, the image at the far right, the concentration of the sodium is now 10 sodium ions divided by 87.5 microliters. This is 0.114. If we multiply this value by the dilution factor of 2, it equals 0.228. Now, if you compare the diluted and undiluted values, you can see that there is a large difference between them, 0.038. This error can be avoided by using a direct ISC. Ideally, to avoid lipemia, specimens should be collected from fasting patients. However, this is not always possible. And as I mentioned previously, some individuals may have medical conditions in which lipemia may be present despite fasting. The recommended method of clarifying a lipemic specimen is ultracentrifugation. Ultracentrifugation uses a centrifugal force of about 200,000 G. The Beckman-Coulter airifuge, which is shown on this slide, was specifically designed for this purpose. The airifuge sample container has 3 compartments. In this figure, you can see the 3 compartments. There is 2 side compartments and a center compartment. The sample is pipetted into the side chambers first, and then the central core is filled. The container is placed into a small rotor, which is then placed into the airifuge for ultracentrifugation. During the centrifugation step, lipids move into the central chamber, and the clarified sample moves into the side chambers. Following centrifugation, the central core fluid is removed and discarded, and the clarified specimen is removed from the side chambers. The clarified specimen is then used for biochemical analysis. While ultracentrifugation is the recommended way of clarifying a lipemic specimen, some labs use high-speed centrifugation at 20,000 G for 15 minutes at room temperature to separate their samples. Lipid clearing agents, such as those listed here, have also been used to clear lipids from samples. A popular commercial lipid clearing agent is LipoClear. Although lipid clearing agents are less expensive and easy to use, they should be used with caution as the clearing agents are known to affect the concentration of analytes in samples, such as protein. Historically, specimens were examined visually by laboratory staff to determine their suitability for analysis. The image on this slide is a hemoglobin reference guide from the CDC website. The human eye is not sensitive enough to detect lower levels of hemolysis icteric and lipemia that may cause interference. In a high-throughput lab, visual inspection of all specimens would adversely affect specimen turnaround time. To identify samples that contain the endogenous interferents, hemolysis, icterus, and lipemia, manufacturers of biochemistry analyzers, such as Beckman and Roche, use multiple spectrophotomic measurements. These measurements are known as Hill indices. Unfortunately, the biomedical industry has not standardized these indices. Subsequently, the indices varies from instrument to instrument. In addition to the lack of standardization, manufacturers decide what level of interference is significant. The Clinical and Laboratory Standards Institute, CLSI, recommends that individual labs test Hill indices during instrument validation and as ongoing quality control. In summary, hemolysis, icterus, and lipemia are endogenous interferents. Hemolyzed blood can cause interference through both additive and dilutional effects, as well as through spectral and chemical interference. In cases of in vitro hemolysis, the specimen should be recollected. Icteric samples have abnormally high concentrations of bilirubin. Bilirubin can cause spectral and chemical interference. Lipemia is caused by the presence of increased lipoproteins. Lipoproteins scatter light. The ratio of the particle size to the incident wavelength of light used in the assay determines the type of light scatter. Lipemia can also cause interference through volume displacement and the partitioning effect. To avoid lipemia, fasting specimens should be collected. Automated analyzers measure the absorbance of patient samples at multiple wavelengths to determine their suitability for analysis. These measurements are referred to as Hill indices. Hill indices are not standardized, and the CLSI recommends the labs establish their own indexes and perform routine QC to monitor these indices. The figure on this slide depicts the absorbance profiles of hemoglobin, bilirubin, and lipemia. Note that the absorbance of a lipemic specimen decreases as the wavelength of light increases. Hemoglobin absorbs light over a broad spectrum. Bilirubin absorbs light over a more narrow spectrum with a peak absorbance at approximately 260 nanometers. The following references were used in the creation of this presentation.